Hello, everyone, and welcome to Talk with a Doc, a new thought leadership series brought to you by HealthSnap, where we hear from the nation's leading healthcare experts on their perspective of technology's role in patient care post-COVID-19. My name is Samson Magid, and I'm the co-founder and CEO of HealthSnap. Joining me today, we have Dr. Caroline Berchuck of Commonwealth Care Alliance and the VP of Innovation and Winter Street Ventures. Dr. Berchuck, thank you so much for your time today. We appreciate you joining us.
Thank you for having me, Samson.
Of course. So I thought we'd start off with an introduction to yourself, to CCA, and then also if you'd like to share with the listeners a little bit more about your career path and how you got to where you are today.
Sure. So I'll start with Commonwealth Care Alliance. So CCA is a not-for-profit based in Massachusetts that serves people dually eligible for Medicare and Medicaid. So it has both a health plan, so it's a payer for duals, and it is also a care delivery provider. And those services range from home-based primary care with the ability to manage high acuity needs in the home, all the way to sort of care management wraparound services for people in the community. So if you can imagine, if you're dually eligible for Medicare and Medicaid, you have significant needs, and they're complex chronic conditions, their social needs, mental illness, behavioral health. There are a lot of things that our membership faces and struggles with on a daily basis that we aim to provide through services and support. So personally, I am a physician, and my journey is a little bit circuitous. What I often say is that I kept my focus on the intersection of good medicine, good business, and social justice. And sort of with that as my North Star, I've ended up both going to medical school and then training at UCSF in San Francisco and following a health systems leadership pathway so I could understand more about the systems and policies and incentives that guide the work that we do. And through that work, actually did a research project where I traveled around the country interviewing alternative payment model primary care practices. So it included ChenMed and IORA and CareMore and CCA, and those really doing exciting, innovative things, mostly in public payer spaces. And I got really sort of excited about those models. So when I finished residency, I called one of the people that I'd interviewed, Toya Ajayi, who is now the co-founder of City Block, and said, I want a job. I want to work for you. I think this is awesome. So came to Boston, and I work about 8 weeks a year at Brigham and Women's as a hospitalist doing clinical work. And then the rest of my time is at CCA. And I do 2 things, as you alluded to. One is work on the innovation team, where we test and evaluate and implement programs and products for the organization. And the other's on our venture team. So we have a small social impact venture fund, and we look for products and programs and technologies that can benefit our population. And we invest in them, we test them, and we really work with those founders to make sure that the solutions that they're developing are aligned with the needs of real people and real people who need them.
Got it. Yeah, that's amazing. We'll put a pause on the venture side and come back to the end of the conversation because I want to unpack that a little bit more. I think it's really unique as a practicing physician and actually as a care management organization working with patients to have a venture side of the organization. If we switch to the CCA work you do and as a physician as well, a part of what I ask everyone off the bat is about, virtual care. It's talked about nonstop, and it's been talked about for the last year tremendously about changing the way that care is delivered and moving it from the clinic to the home. So I'd love to start off with asking you the point blank question. Do you feel virtual care is here to stay? And then as a result of the last year's work, how has CCA's strategy around virtual care changed, if at all? And how do you view that in the future as well?
These are great questions. So I'll start with where we were a year ago today, I should say. My husband and I were flying back from Miami early as the pandemic was really starting to take hold. And I got a call from our chief medical officer and our one of our SVPs and they said, we've never done a virtual visit in our organization's history. CCA started in 1974, was the predecessor organization, as a home-based primary care practice for people with disabilities and advanced HIV. We are a high-touch model, people in the home, all licensures. We do a lot of phone calls and texts, but never what we would call a virtual visit. Didn't feel like it was in our DNA. That obviously changed very rapidly. And I would say we initially thought of virtual care as substitution for the in-person visit that we could not do at the time. And even now, I would say that's where many organizations are, is there's virtual substitution until. And that's kind of a thought process that has taken hold of some healthcare organizations and big systems. What I would challenge, and I think that we're at CCA are starting to think of as well, is that it's not virtual until, it's virtual and it's not about having one or the other, but it's a true integration of models. And that's a pain point because I think the tendency is now that our staff is out in the field going to members' homes again, we think it's actually, we're wondering, do we need to do all of this all the time? What are the parameters? What does that look like? I don't think anyone knows yet. Certainly there are some really smart, wonderful people trying to figure that out. But what I would say is that when an organization, a nonprofit that's been around for 47 years, can go from 0 virtual visits to 7,000 in 6 weeks, then it is with a highly complex and technologically not savvy population that we also are training and scaling up and teaching how to use these modalities, then anything is possible. And I really challenge us to think about what is the best care. It's not virtual care, it's not in-person care, it's just care. Yep. And so how do we really integrate those models to do what's best for the person and best for the clinical need at that time?
Yeah, I love that. And I actually just did a post the other day about, like, it isn't an either or thing. It's just deliver care to the right person at the right time through the modality that they need at that time and based on acuity, right? I'm curious to hear, though, if you unpack that a little bit, like, what are the challenges that you guys are seeing, though? Like, when you start talking about making sure that patients are reached out to and getting the care at the right time and in the right modality or setting, whether it's the home or in the clinic, how do you distinguish that? How do you know which patient should be in the clinic or getting the care at the home? And how do you prioritize one over the other? And I'm curious, what are some of the challenges you guys are seeing when you start thinking through those problems and discussion points?
That's a great question. I think that for people for whom a virtual first model or virtual integrated model was their starting point, that's a question you have to ask from the beginning. And we were not that group. We are an adapter, not the ones who initially said, this is the way we're going to do care. So we're still figuring that out. I think 3 things come to mind as extraordinarily important for us to understand before we even answer that question. One of them is, what do our members, which is what we call our patients, our population, our beneficiaries, what do they want? What do they like? What do they use? They are owners and stakeholders in their care, and their voices matter. And they come to us for 3 things: medical care, behavioral health, and social needs. And we want to be able to provide whatever services they need, how they want to receive them. And so that's the first thing I want a better handle on, is what do people actually like and want and trust? And that goes to the technology piece as well. Virtual care has the potential of being bifurcating for those who don't always have access to the technologies to actually do it. So we focused a lot on how do we democratize access to virtual care? So that comes through making, from the start of the pandemic, we did surveys of our members of what's already on your phone. Do you have a phone? What do you use it for? Do you have data? Do you have Wi-Fi? And we were doing things like figuring out ways to get unlimited data for people that didn't have Wi-Fi, putting hotspots if we needed to, sending out phones or tablets. And also, use WhatsApp. We don't have to do something fancy. If you like WhatsApp and it's on your phone and that's how you communicate with your family, let's just talk on WhatsApp, which we could do at the start of COVID. So that was really important to us, was really meeting our members where they are and then using that relation to sort of scale up their tech experience and education and literacy. The second is what you talked about, the clinical pathways. We need to understand better. We need to challenge our assumptions for what those pathways are and how we deliver them. I think I'm a physician. There's a paradigm that we tell ourselves that we train of like, this is how we do things. And I think COVID's really challenged that. We know hospital care doesn't need to be in a hospital. It should just be called, high acuity care. We can deliver it a variety of places. Right. So challenge clinical pathways. And then I think the last thing I would say on issues that we're having, for our population in particular, investing in social needs has a greater impact on total medical expenditure than healthcare alone, or even healthcare sometimes at all. So then health costs. So say by healthcare, I mean medical costs and billed costs. So we really have to think about virtual care, not just as heart failure management or diabetes management, but as the entry point into someone's home. We value home-based care at CCA generally, but with you have a video in someone's home, you have a shared experience to understand that person so much better. And you can say, can you show me your refrigerator? Would you mind opening it so I can see what's inside? Gives you an idea, do they have food? Do they have healthy food? Then you could say, show me your medicine cabinet. Show me where you store your medications. That's really helpful. And, we have such an intimate experience. Intimate experience. And I think that's really important. So those are my three things. What do people need? What are the and the social needs, and then the clinical pathways.
Yeah, no, that's amazing. That's a great summary of it all. And it goes back to like, how do you enhance the provider-patient relationship and use the word trust? Trust is such an important thing, right? Because you are getting access to things you normally wouldn't be through technology. And it's the first time I think a lot of, I'm sure, caregivers and patient or members are using technology in that way. So the trust of all of this is so important early on, I'm sure. So you talked about a lot of things that I think is a good transition point into the next question, which is, I always ask everyone on these sessions about value-based care and shifting from fee-for-service to value-based care, or however you want to, whatever buzzword you want to use of, volume to value or prevention over treatment or whatever it means to you. But it's been talked about for a long time. And so, you have a unique purview, again, as a practicing physician in an organization that is dealing with at-risk populations that are highly underserved. And I'm sure, value-based care is what's, the center and the ethos of what you guys do every single day. So number one, what does it mean to you? And then number two, like for an organization or an industry at large, like what do you feel like needs to happen in order for it to come to fruition, or however you want to call it, whether it's value-based care or patient-centric or outcomes-based care? What needs to happen in order for the industry to move towards a sustainable model?
I love fun and hard questions like this. You're talking to someone who works in an organization that's been doing risk-adjusted capitation since the 80s. So for the last for as long as I've practiced outside of residency here on the CCA side, that's all that we do. We're full at risk, global cap. We have a Section 1115 waiver, which means that we get to use those funds more flexibly than many organizations do, even those in risk contracts. So we get to cover more social needs and services, and again, the stuff that tends to impact total medical expenditure more than medical cost and medical care. So we love it. We think this is great. But we are also a health plan, right? So we're a care delivery provider and we have a health plan. Not everyone in our health plan gets all of their care from us in the care delivery space, and we don't own hospitals. So we are an asset light managed care organization. So even the people for whom we feel really good about the whatever you're calling it, the value-based care that we're delivering, they still go to hospitals. So, even those people have been doing this for decades, do not control the care continuum. We cannot align all of the incentives well enough to get to a place where we feel like value has been optimized and fully created. So you had two parts to your question, like how I feel about this and like what does it need? Yeah. So I feel that the same thing that I said when I was about what I was thinking about in residency, we've got to align incentives. We need that person, that member, that consumer's needs to match what we are excited and willing and able to deliver. And until all of those pieces line up, we're not only going to not control all of the cost and not optimize value, we're also not going to be doing the right thing for people. So, when I think about what does value mean to me, it is also consumer-centered and also consumer-driven. We need to design our systems and design our payment and design our outcomes to best meet the needs of people. And we just don't do that as a collective. And so what I think personally needs to happen as a hospitalist, I'm saying, is we've got to control the acute care costs. We need people in risk-based contracts, including CCA, anyone who's really doing primary care risk and primary care cap, they cannot take on until they actually have any type of leverage over a hospital system or can do that care better in a different place, which turns out most of the time it can, and COVID has shown that, then you're going to have limited control over the whole spectrum. So that's what I would do if I were in charge, is I would control the hospital costs.
Got it. No, that's great. And I appreciate the sentiment there. I think there's a lot of moving parts, right? So you tackle one at a time, but they all keep moving. But keep chipping away at it. All right, we'll bring it full circle now. You mentioned about the non-for-profit investment team, and you as a practicing clinical physician have some really unique purview and insights, I think, on innovation, entrepreneurship, new technology, deploying new technology, and how you guys think about that, and working with startups. So would love to hear your thoughts from a venture perspective, how you guys work with entrepreneurs, what you would look for, how you identify the right technologies, like what does that process look like? And I think it's a really, really interesting topic because we do have a lot of, new exciting ideas that pop up every single day. And I think COVID's been a really great spark for innovation in health tech and digital health. But then there's a whole another side of that as a clinician and actually the real world of what actually needs to exist and what are the barriers to make things work in the real world. So I'll let you go from there and hear your thoughts on that.
Yeah, I mean, if you'd asked me 10 years ago if I would know anything about venture capital, let alone work in it, I would have probably laughed. The most I knew about VC before coming to CCA and ultimately getting involved in it was just living in San Francisco and probably whatever I'd taken from osmosis from being in the Bay. What I love about venture, and I just should say, it's the power of the dollar to support causes you care about and to support things that benefit those you serve. And that's how we think about venture, is that there are many returns on investment. Some are financial and some are about the quality of life and the quality of product and advancing the world for underserved and vulnerable populations. So that's how we think about venture as a vehicle. And we prioritize supporting underrepresented founders, and we only invest in things we think would benefit our population. What I think is interesting about being a clinician in venture is that my first oath is do no harm. And I think when you're looking at emerging technologies and you're talking about testing them and evaluating them and iterating quickly, kind of the way in which you might in an innovation or venture space, it can be very uncomfortable as a physician, because what if it doesn't work? What if you're piloting a product that's awesome, and you're talk about trust. Your members love it. They come to trust you and the device, and maybe the company falls apart. Maybe it ends up having a flaw. Then you've potentially threatened those trust relationships. So we can't practice. I think we have a higher level of fiduciary duty, and also just duty to our people to select, invest, and support in things that have good teams, good outcomes, and maybe kind of like, they're not late, they're not early, but they're somewhere in the middle, where we do not like to be the first customer. We don't want to just practice. And I think so when I think about venture for our population, it's complicated in that way, right? We want to choose things that really democratize access to care, that improve the lives of people who've often been left out of technology. And, like we were saying, they may not even have a phone. So we're in this kind of a different group, and we want to serve them well. But venture is a huge opportunity. I mean, look at what you guys are doing, Samson. I mean, I think that we think this is our way in which we want to make the world a better place. And going back to that intersection, there can be good business, good medicine, and social justice can all come together. And venture, money's power, and you can use that money to support things you care about. So that's how I think about venture, and that's generally how CCA thinks about having a venture fund. And I think it's a great way for organizations to have a seat at the table as these cool technologies are emerging.
Yeah, 100%. So we'll wrap up with top of mind, right? From a venture perspective and from the clinical side, what are some closing thoughts? What are top of mind things that you're thinking about for the next year, 5, 10 years, things that you'd love to see that you haven't seen yet? Like, what are things that are exciting for you now in the the technology or digital health or health tech space that you're really excited about, that gets you up every day?
Yeah, so I love what I do. So excited to get up every day and think about this stuff. Top of mind for me is the home as a place to deliver care. And I think about it not just deliver, we've done primary care in the home, many organizations have for a long time. I really want to use technology to provide a higher level of care in the home to make people's lives better. And this ranges from what I call hospital at home light, stuff that doesn't need to be in a hospital. I want to challenge that. What really needs to be in a hospital? Can we do that in the home? Urgent care in the home, treating kids. The number of parents who sit in an ER for hours with their kid who has an ear infection, just send someone to their home with a prescription who can look in their ear, just stuff like that. We can change this. Life can be better. The healthcare system can be better than what we currently do now with with our hospital systems. And high acuity care in the home, number one. Number two is in the behavioral health space. I think we have huge issues on number of providers and prescribers and sort of licensed therapists, and it's a big need. COVID has just augmented that need for mental health care. So I think that having addiction services in the home through virtual and including prescribing is hugely important. And so that's number two. And the third piece is chronic disease management in the home. Ongoing, using intermittent monitoring and clear clinical pathways to integrate virtual and in-person models to manage complex chronic diseases in the home. So those are the three things that I'm thinking about every day. And I think many other people are too, but I would put those at the top of my list.
Awesome. That's awesome, and great way to wrap up today's Talk with the Doc session. Dr. Berchuck, thank you so much for your time. This was really, really awesome. I'm excited to share this with the world, and thank you so much again for appreciating it. Good luck with everything in upcoming endeavors.
Yeah, thanks, Samson. This was great, and we'll keep in touch for sure.
Absolutely. Have a good one.
All right. Have a great afternoon.